All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today with us, our own Paul Bork. Let's discuss COVID and excess deaths and polio. Take it away, Paul.
Thank you very much, Mubin. Okay, yesterday, Mubin was talking about the. Thank you very much, Mubin. Okay, yesterday, Mubin was talking about. You've got the echo. What do you want to do?
So you may have to log off and log back in. In the meantime, I'm going to sing songs.
You've got the echo. What do you want to do?
So you may have to. Okay, so guys, I'm just going to quickly refresh my browser as well. And so just give me 1 second. Okay, Paul, let's see what happens this time. I'm going to mute myself.
I'm back.
Okay, Paul, let's see what happens this time. I'm going to mute myself.
I'm back.
Okay, Paul, let's see what happens this time. I'm going to mute myself.
I'm back. Okay, I turned my speakers off. Hopefully that will work. Very good. So yesterday, we were talking about the UK's decision to not have the vaccine for younger people. And one of the, Mobeen was talking about, they probably had some data. Well, here is some data from the ONS, so the site here, that supports exactly the idea. They have primary school pupils that showed up having a little over 80% antibody rate with no vaccination at all. And with the secondary schools, which have vaccination providing 65% having vaccination, they've got 98% overall. So this is probably the data that was referred to, and I thought I would just start off with that here. Next, we'll talk about the excess deaths, and the UK Office for Health Improvements and Disparities came up with some graphs, and a number of folks have looked at it and been concerned and going forward. But when I took a look at it, we have here in the graph above, these are total deaths, and we have the mortality above the line is excess and below the line is deficit. And if we go past right about here, where the last big wave of deaths occurred in the beginning of 2021, we have sort of offsetting areas that appeared going forward. Now, this graph down here is the same, but they also have included this yellow zone, which are the COVID-19 mentioned on the death certificate, and these are marked separately. And so again, if we take a look here going forward, it looks roughly that we're about neutral on that. And so if I go to the next slide that I have here, I've taken just that space on them and cut the other off. And so again, I think you can take a look and just get a rough idea that it looks fairly offsetting. And then we have here the excess deaths. They've excluded COVID supposedly in the 5-year number from what their citation was or description of what this line was. And so we have the COVID deaths and then the other deaths coming up to it. But if we dive in a little deeper, go take their data. And if I go take the data here for this graph and I subtract out the COVID deaths themselves from all these, and then go ahead and plot that, which is what I did, we get a graph that looks somewhat like this, where these are excess deaths coming down, and this is zero line across here, and then it drops down, up and down, and whatever. And at least squares line, you can see that it is almost completely random. We have less than 0.08% of the explanation or of the variation can be explained by progress going forward here. And so the average shows that there are 452 deaths less than what the 5-year average has going forward with it. This is one way to look at the data. But if we go back and take a look at this, we're just counting excess deaths. And for example, on this point that's way down and this point that's way down, an extra 50 might be a larger effect than it would be if it was up at the higher peak. So another way to look at the data would be to take the percentage of the 5-year average, and this is taking the percentage. And again, we get a little better fit, but 1/3% of the change is due to time going forward. And we have, again, 450 deaths fewer than what was here we've got about 4% less deaths than what was anticipated. And we go back to this other one, this being 1,000, this is about halfway, that's about 452. And here, if we do the percentage, we have about 4% deaths lower than what would be expected for this time frame. So let's go back to the original graph. We have higher deaths for COVID for these two, and then starting from about here going forward from the beginning of January 2021, it appears from the data that there are no excess deaths. There's actually a shortage of deaths. And so it's suggesting there's nothing major going on right now. There may be something later on as a side effect from COVID, but right now there isn't. And again, I'm reminded of what the police officers say, at least in the movies, nothing to see, move along, don't spend any time looking at this. And I was surprised. I expected to see excess mortality when I looked at it. And so it seems that the fewer deaths may be really due to an earlier death from COVID of the fragile folks, the folks that were destined to die today or next week or next year have already died because the COVID came in. There were an awful lot of people that died everywhere, unfortunately. And so those folks whose time to die, if they hadn't gotten infected, would have been today, are gone. And so maybe that's where this deficit of deaths are coming from. Maybe there's some avoided deaths that from some other reasons, people not driving, people doing things differently. And of course, we would expect there to be increased deaths from misdiagnosis, from mistreatments, delayed medical treatment, harm from isolation, psychological, other non-infectious impacts of the pandemic, such as, the few people that are killed by vaccines or other things that are coming from that. Yeah, John, you may be quite right that they're already dead. At least some of them are. And but we're having a very consistent number. If we take a look, either the actual number or their percentage, it's very, very flat, the deficit here, and it's saying across the board. So it may very well be that a certain population of whatever age group going across, the more fragile people are just gone, and they can't die now because they've already done that. And if we take a look at the cumulative excess mortality, and I selected these countries by just looking at what the highest daily cases were for in the Worldometer. And it includes the UK, and you can see their excess mortality coming up and then drifting down. So this graph is confirming or consistent with the other one that they're having fewer excess deaths, excess mortality from about this point in time than what they had than what was expected. And so they're still 10% above. And so we've lost a lot. And Russia's up here at about their reported number is about 27%. They were up at 30%, and their number coming down strongly. So right now, Russia may be having the same thing with fewer cases of death than what were expected. We see Brazil following the same type of curve. And we see France sort of sloping down a little bit, South Korea coming up, but the United States coming down, Hungary, Hong Kong, that's Italy here coming down as well. And this is probably a reflection of the fact that the Omicron is killing fewer people than before, and we're catching up with the deaths now from, I've removed from the graph I looked at before Omicron, but SARS, which would now be mostly Omicron, but this cumulative excess mortality does not have that. So this is looking at the total, including any COVID deaths that are occurring. And you can see the UK coming down, but now then it looks like it's sort of slightly coming up here. But the numbers that we had from the other government agency, it wasn't the Office of National Statistics, but the other UK government seemed to say that there wasn't this gradual increase that's going on. So that's what I have on excess mortality. What the insurance companies were reporting at one point may have been accurate at that time. I don't know. I don't have a number for I don't have an express number for the US, but we do have an indication from the Center for Disease Control that the deaths in the US are coming down. And if we take a look at the curve here, from this point in time for the US, we are actually having fewer deaths than what would be expected. So however many are dying from COVID, there are fewer people dying from something else. We could look at the different age groups. I have not done that yet. The UK data was stratified, but I was just looking at the excess and trying to just have it as a part of the talk here. Okay. Now, we had talked about polio before. We still only have one US case of polio, and it's derived from the vaccine, not from polio itself. It's found in the wastewater. Now it's in New York City, in many of the boroughs, and 3 contiguous counties, and so they're going forward. The New York medical folks have declared a statewide medical emergency for it, saying on polio they simply can't roll the dice. And that main reason, I think, for that is allows broader vaccination. There doesn't need to be an individual prescription, as New York apparently provided before. Midwives, pharmacists, and EMTs can also provide the vaccine. And part of the reason why for that, looking at what we had before, saying that a 94% vaccination rate is needed, and some of the counties are down more about the 70%. So if it starts spreading, they'll want to be able to have the vaccination rate jump back up, and that's probably why they declared it. If you remember, we have 3 different wild varieties, and 2 of them have been eradicated. There's only 1 that's left. If we take a look at the countries from before, the countries over here are where there is polio ongoing, the wild type, and these countries are countries that are getting the weakened polio from the vaccine. They're using the cheaper vaccine. It can be stored better and is cheaper, and has occasionally people get infected from it. Any other questions on that? Okay. Interesting, the Wall Street Journal yesterday reported that Johns Hopkins is slowing their updates. The state data is coming in slower, and Massachusetts, apparently, they said it was only going to update their data weekly. And so Johns Hopkins was doing hourly updates and decided that they could move to a little longer. And they talked about how their website came up. And they said that it came from a discussion with a professor and 2 grad students. The professor apparently was promoted in a brand new position, and the grad students weren't even mentioned. So some folks may think that's exactly how grad school works. But they apparently constructed the web page in 2 days and have been running it the whole time. They've got 800 million hits. The CDC adopted it as their place to get data. But the slowing of data may also be why, if you remember, the CDC is now taking 3 weeks for their forecast on variants, and it may be part of the same effect. It may not be. It may just be that things are happening to the CDC versus the CDC making a decision on it. Now we go to where in the world is COVID. If we take a look here, we have, again, these are the countries that had the highest rates. Taking a look, and here we have Hong Kong peak in cases. Here, Hong Kong peak in death. We have South Korea peak in cases. South Korea or Taiwan here, and South Korea here and here. And so we're getting the reflection of the curves. You can see the death curve is broader than the case curve, probably because treatment is such that everyone who gets infected or goes to the hospital or gets diagnosed on a given day, they don't all die at the same time. Some take a little longer and they're treated more with a longer treatment period before the treatment fails, and hopefully they don't fail. And here, if you see, this is an 8,000. And the deaths are at 35. And so the vast majority of people are surviving in each of these areas. But if we take this just a background to show where they are, the cases here at 30, the deaths at 35, the cases at 8,000. And if we look at where we are right now, this is now 2,500, much, much lower. And here are the list of the various places: Taiwan, leading, Hong Kong, South Korea, Japan, a lot of the Asian countries that did not participate very heavily in the first part of we've got Germany, Russia, France, Italy, the US, and Brazil, and these countries did participate fairly heavily initially. The hospital admissions, a lot of the countries aren't reporting it, but the countries that are, Russia has a brand new high infection. Is this because of folks involved with the Ukraine going back and forth and traveling different, or is there something else going on? I don't know. The US rate, you can see, is dropping a bit here. Patients in ICU, again, not everyone's reporting it. We've got France, United States, South Korea, Germany, and Italy. And if we look at the deaths, here, again, this is 2.5. The other was 35. And so one can say Japan is the highest right now, but they're at very low level compared to where they were before. Then Hong Kong, Taiwan, and then the US. And going back and looking at it, you can see that's this curve here blown up. So it is relatively flat. We're not having a lot of excess deaths reported among those folks that are listed here. Any other questions, concerns? If we look at the next strain, we are talking about variants and how many are coming in. And from what I'd said before, I think is still true, that we're having a fairly flat rate once a variant is set going forward. You can see these rates all look fairly the same. These purple lines are all the same slope. And we seem to have the cases started and then it jumps up or jumps down. I mean, we had this, and when this Delta came in, it jumped down. Then it seemed to jump up with a lot of mutations for a new variant. And once the variant is going, it seems to be at a very consistent rate. And this rate is 12 substitutions per year. If they just go from when they had the first Wuhan up to where the least squares curve, the least distance on it, they get 34. And I think the rate here is higher than what we would see for inside a given variant, but this is the rate that they're seeing overall, counting the changes in the variants. And the ones that they're looking at are still the same ones that we had before. They're not looking at the BA 4.6 or anything. Well, I think each variant will die off. The question is whether they keep getting new variants. SARS-CoV-1 would still be around if they kept having new variants that could infect folks. So I don't know. And here we talk about the new variants here. Again, we now have the 3 in the nowcast, and the CDC is saying that cases are coming down a little, deaths are coming down a little, hospitalizations are coming down a little, and the people over age 5 with the first booster is only 35%. That number has not changed markedly in quite a while, as I remember. And here I've highlighted the BA 4.6, which is the one that's growing. If we take a look, we've got the BA5 flat actually starting to decrease here. And the BA4 is decreasing, and the BA46 is the only variant that is increasing. These are new cases, and so the vast majority of the existing cases are going to be BA5 from essentially the integration, all these cases, all these people that are infected, because again, this is only looking at new infections. And so we have the BA46 growing, but growing much smaller than any of the new other variants have grown. And so the BA5 should be around for a while, and the BA4. I think last time I estimated how long it would take for them to take over completely, and it will be months for that. If we take a look at this, this is the one we had before. If we go back, you can see the numbers are higher, but the various regions, we have essentially the same distribution that goes on. So one of the things that we can do, I took a look at each region separately, okay? And if we sorted them based upon the change that occurred versus where the concentration was, we seem to get sort of an inverse relationship where the areas where the BA46 is the highest seem to be increasing sort of the least amount that going forward. And treating, it's not really right, but treating each of these regions as if it was an individual different area and looking at the rates, we get an average September 10th of about 8.6, and the average today is about 6% growth per week. And we look at the standard deviation, the variation among the various 10 regions in the US, we get 50 to 70% of the average is a variation. So we have an awful lot of variability that's going on with that. But if we take a look at the BA4, the region, the one that's decreasing, the standard deviation is only 13% of what the number is. So it's only about 1/6 as much versus the average. And so it appears there's something radically different going on with the BA 4.6 than there was with the BA4. The BA4 seemed to have spread across the country a lot more evenly than the BA 4.6 is. And so this infection with the BA 4.6 may be quite different than what we've seen before. Let's see, where am I now? Okay. And so here I took a look, I had each of the regions here, and we have the orange spots are 1 week and the blue spots are other week. And since obviously infection is going up, the orange spots are the later one. And if we take a look at this data and put it in and do least squares, we see that we have 32% of the variation explained by the change in infection. But we have these 2 spots that are way up here. So doing a sensitivity analysis, dropping those 2 spots out, we went from 30% of the variation explained by the increased concentration of the infection, and taking out the 2 highest ones, it then explains only 2%. And so this is, we went from 30 to 2, and for the lower one, 50% to 11. And so it's saying that there really isn't a downward slope. There's a lot of, and you can see this, the line, the slope here is much steeper than the slope over here. And so there is still some downward sloping, saying as the concentration is getting higher, the rate that it's progressing is getting less. That may be that the BA 4.6 works better against the BA 4 than it does against the BA 5. And as the BA 4 is being taken over faster, that the BA 4.6 may move even slower than it has already. And if we go back to the curve here to see it, you can see that there's still some BA 4.6, and it's right, we're just passing from the nowcast the point where the 4.6 and the 4 are at the same level of infection. So hopefully that all made sense. But it's saying that there's something different that's occurring with this, and it's taking over less quickly, and it may slow down even more as the percentage of new cases that are the BA 4.6 comes in. And it may well be then that if we have a new variant come out, it may be that it takes over before the 4.6 ends up with close to 100%. But it may also mean that the BA5 may sit around for a period of time longer, and the folks that have been infected with the BA5 may be more protected than if they were infected with another variant. So we may end up with more protection as a result of this slower growth. And now going to the Zoe app and the UK, we see, as I said, I thought this would come back up and it wouldn't cross the 100,000 new cases a day coming in, and it is starting back up. And these red lines, as always, are the same slope, and this is the slope of the increase with the first Omicron. And the second one you can see was markedly less fast where it came up, okay? And this one seems like it's even going to be slower. And maybe we'll get more of a flat peak here. I don't know how high it will go. That'll be based on how many people get infected. But since it's seems to be infecting slower, we'll go forward. Now this does, and the R is reported at 1. Obviously, it's more than 1 since it's going up, but they reported 1 for some reason. And we don't have the Queen's funeral where an awful lot of people got together. We don't have the new fall starting yet. We haven't seen that yet, apparently. And the down here, the increase, this I did look at the age distribution, and the 0 to 17 is starting to increase just as it did at the beginning of these 2 waves. Yeah, I know the students are back, and I'm teaching some, and I know the students are back, but we haven't seen the increase from the students coming back yet. If we take a look at this, remember that the increase was slower, and the decrease seemed to be more rapid, and so there were fewer people. I don't know what the next curve will look like. And here before they said the R was 1, and it was 111,000 cases, where now it's 112,800. So R is better, higher than 1. I don't know how they go about calculating it or when they update it, but clearly it is. So taking a look at the Office of National Statistics, and this is based on going out and surveying people, grabbing people on the street and finding out if they're infected and seeing what symptoms they have. Okay. I see Zoe is showing that. And we have roughly over the whole time between 30 and 40% of the people saying that they have no symptoms at all. Given the sort of sampling that's going on, I expect there to be some noise here, the number bouncing back and forth being more due to random variation than perhaps due to different variants. Shortness of breath, there's a significant drop. This is the Omicron. Sore throat. Fatigue, weakness had a little decrease, but not really as much. And the rest of them seem fairly level. We go to the Zoe app, and they're obviously only talking about people who have symptoms. They're showing the numbers change a little bit from week to week, or I guess they're doing it every 2 weeks now. They're updating it. But sore throat, headache, black nose, cough, is the same sort of things before. And the loss of smell is way down. Now let's talk about long COVID. If you remember before when I was talking about it, I said it looked like it was leveling off, then going up and leveling off, and then we had the first decrease. Well, they haven't put together the graph again, but the last data point was again 3.1, which is right where the other point was. So I added it to the graph. It looks like we're seeing the essentially flat increase, flat increase, flat increase, which is essentially what we would think would occur if there really wasn't a significant recovery for a lot of the folks with long COVID. And so now it was down to 1 in 36, and this was at 3. It's now 3.1, so it's a little better than 1 in 33 people having COVID, maybe down at 32 or something like that, having long COVID in the UK. And this is just the same data, but a different graph showing where it's going. And this being 3% of the population right here. And they're back up at 3.1. And that's what I have. Any questions or concerns that I can address? Very good. So I think we can have a nice short lecture. Death rates. Yes, death rates are down. We talked about the excess mortality that folks were having. If you remember the graph that had here, I'll put it back up. Okay, here are the excess deaths. COVID deaths are the orange line here. You can see in the UK, they're still going and going forward, but they're down a fair amount. If we go to the cumulative excess mortality, you can see that the rates are coming down, and where they're coming down, that means fewer people are dying than what was expected. So what would have occurred before COVID occurred. And so the UK came down here, and then it's looking fairly level, but the data is fairly consistent with the other data that has been reported. And you can see Germany, it came down a bit, and it's now coming up a little bit. The US is coming down, flattening off, but still coming down. So for COVID deaths, total mortality in the US is less than what had been expected. Brazil is coming down, and Russia coming down very significantly. The initial studies have said that it's not. That's based more on some of the treating doctors saying they haven't noticed anything than any study that I've seen. 4.6 is still fairly young in terms of having someone look at something, study it, get a paper, get it published, and go forward. That one's for you, Mobeen, I think.
So hopefully there is no echo. So yes, COVID can cause urinary frequency and urinary problems. Fortunately, they seem to go away as well. This is mostly, I believe, an indication of autonomic nervous system dysregulation. So yes, this can happen.
How many people in the world have long COVID? Well, if the UK has 3%, and you see their number has been fairly steady for a long time, what's 3% of the world? Right. If excess mortality is positive, it's more than expected. If it's negative, then it's less than expected. Now, I said the 3%, but countries like China and Australia and New Zealand that haven't had very many people exposed because they've been hiding away from separating the people from COVID, they may have a lot lower rates than perhaps the UK does. And we're seeing the UK ramp up. So it may be a function of total number of cases. But the only real number I have is the 3%. And if we take a look at countries that have essentially had everyone exposed 2 or 3 times, then I think that's where the UK is. Everything I've seen says that the long-term rate is essentially the same as a function of infections. Developing countries better off versus excess deaths. Some data shows that. A number of people are fighting against the data, saying that they think that the developing countries aren't telling the truth or don't have good reporting or they don't care about their people or whatever. I don't know what the I don't know what's really going on with it. There's so much variation from place to place. It's really hard to get good data, and there may be people that are trying to change numbers. So I don't know. I suspect a lot of people are going to get sick, get infected. Hopefully a lot don't get disease. If you remember what Drbeen was talking about yesterday, infection means the infectious agent is inside the body. Disease means that you have an adverse effect from it. I suspect and hope that we'll get stronger immune systems, better recovery, and get folks that are infected, but a lot more that are asymptomatic. Well, we're having mild symptoms. People can still get affected from it. People can still die from it. It's a policy question. It's not a medical question. How much of a risk are you going to take? Do you walk across the road when you don't see someone coming and the light is against you, or do you go ahead and say, I can make it across? I mean, it's the same kind of question. What kind of risk? The only real difference here is the person that's going to get hurt or die is different than the person that's taking the risk.
And Margaret from CDC.
Should everyone wear a mask? Clearly, you'll protect more people. Is it worthwhile? Should everybody stay home? Should people not go get coffee? Should they not go to the post office? Should they not do whatever? You have to decide what it is that we're doing. And I do believe that different doctors' offices are making different decisions. And I think it's a lot like, McDonald's, Burger King. If you're going out, you get a different thing. You should decide what it is you want and select as much as you can, move towards that you can do. Unfortunately, we're having a lot of the medical providers being bought out and having large organizations that have consistent rules, and you don't have the same number of choices we had before.
Plus, the CDC has really reduced the duration to stay indoors after the testing positive or symptoms.
Talking about 4.6% with long COVID. Is that the question, John? Yeah, CDC says a bunch of things that aren't really medically driven either. They're looking at policy questions, as they have to. I mean, it's appropriate. They're not a medical organization. In my mind, they're a medically driven political organization, and they're making decisions and recommendations based upon policy considerations. But if someone is really at risk and you've got someone who has COVID and you're very sensitive and someone has COVID at the doctor's office, you're going to get exposed to it. So. Reporting excess deaths is very difficult to take a look at, and vaccines are different all over. I mean, you look at the Chinese vaccine that they wanted, 3-4 vaccines with a Covovax to be, and you've got the Russian Sputnik vaccine that was viewed by Venezuela and some other countries as not being effective. How do you take a look at that? Yeah, even the Russians should not lick pencils, I think. I've heard any number of people say that they have fully recovered from, and a treatment that works for one person doesn't work for another. We've had a number of, you got your coffee prescription. We have a number of folks, doctors that have come in and say, I try this treatment and 20% get well, immediately 20% get worse, and 60% has no effect on. I try something else. And so I think it is not a disease, long COVID. It's a syndrome where it's a number of diseases that look the same. And I think the treatment's going to be different. Masks and washing hands and distancing are different things. They don't really address the same. But you could look at it and say, my overall risk is here. I'll take the risk of the mask and and wash my hands. And I guess I would be happy that the microbiologist is at least washing her hands.
Yeah, and if not masks, then nasal sprays are actually very, very
But
useful.
I would take a look. My wife is kind of hard of hearing, and wearing masks, she realized how much lip reading she was doing. And it really creates barriers for some folks. And so when you make a change, there's always unintended changes that go forward with it. And so again, wearing masks may have some benefit, but it may also have some problems for some folks. And your microbiologist may have said that she's glad they stopped wearing masks. Might have been one of those people that either where she was talking to folks or herself, that she was having trouble hearing and being able to see where people are going. That may have been her response. I don't know. Justin, glad to hear you're almost fully recovered. Marvelous. There's a lot of different studies and they show a lot of different things. I still think that we need to keep in mind that vaccines, the whole idea of a vaccine is to approach or approximate the person that got infected and their recovery without putting them at risk of getting the disease. So if we're just talking about strength of resistance to COVID, the best thing would be to have the infection, or not recommending anyone does that. But when you take a look at the different vaccines, different studies at different times have shown different ones to be better or worse. Right now, most of them aren't showing very long effect. Clearly, it is not relaxing around you. So that's, I guess, what the microbiologist was saying. So I'm sorry to hear that, Bambi.
So a few days ago, my wife gifted me this cup. So she brought it from somewhere and she said, "This is for you." Actually, she was traveling and on the way back, she brought this for me. I really love it.
Sure, molecules go through it. Viruses can go through it too. The question is, the virus can go through the mask of any size that you can breathe through. The question is, the virus doesn't go by itself. It hasn't been powderized, or as they say when they talk about chemical weapons, it hasn't been weaponized. So it's air dispersion. It's stuck in mucus, and the mucus parts get stopped. Some of them do with any mask, and the question is what size mask. I believe the study that just showed the gator things actually increasing infection because they took the large mucus particles and made them smaller and caused more of a problem with it.
Plus, masks also have the electromagnetic or charge in them, which can also interrupt or disrupt the viral movement.
I do not know who it was, and since it was one person, my bet is the medical information would not tell you very much at all about that person, because unless they wanted to talk themselves, the family, the HIPAA information would shut that down. But it's important to know from an overall risk standpoint, we're talking about one person. How many people die from various things of monkeypox, if you can do behavior to protect yourself going forward. And I would suggest to Mobeen that actually for the immune system, the first level of defense is the brain. Don't put yourself in a position of risk. That's 100% effective. I put a mask on. That may increase my protection or not. But if we go forward and say, well, the skin is the first layer of protection, and we're talking about monkeypox, that's assuming everyone got the same exposure. They didn't. They won't. They can make those decisions to decide what they want to do or not do. And so, again, I think as we take a look about the monkeypox and people got all excited about it, given all the other things that are going on, particularly if you look at the undisclosed pandemic of diabetes and overweight and all the effects those have, that be far more important to try to address that than worry about that you're accidentally going to bump into someone on a bus that has monkeypox. And clearly, if you are like any number of us that wash our hands when we come in from outside and try not to touch anything of mucus before you do that, you're probably going to be 100% protected against monkeypox unless your skin gets cut or something, even if you happen to bump into a person that's infected. So again, it got a lot of views, and people are really excited about it. And it seems like there's other things that would be more important to look at from a medical standpoint.
So, Doug, the normal surgical mask, the one that are made to standards, they're made of the material that has electrostatic charges in them as well. And that is a contributing factor. And as somebody else said, if there are holes and there are leaks, then of course, these are the areas from where the exchange can still occur.
And I didn't hear what you said, but my understanding is from 3M is that most of the 3M 95 and higher masks have the what they call electrostatic, where they have different charged and it attracts them. The main difference for the medical and the non-medical is the medical has a water barrier, so if a fluid comes out, like someone throws up or they have a punctured artery, that it would protect the person. The non-medical masks don't have that layer, and so if you get a non-medical mask, the only thing you're giving up is the water protection layer, I believe. Is that consistent with what you understand?
Yep. So
Nope. I haven't heard anything about. What may happen is the people may get an infection and form antibodies from what they got, rather than the antibodies crossing over. Antibodies could be stuck to a particle and come in, but I never heard of them proliferating or lasting a long time in a body.
correct. And Robin, all of our mucous membranes have antibodies in them, IgAs. And so if we spit, we actually have antibodies and many lysosomal enzymes and many proteases and other things which are uh, actually protective for us. That's why we have all those substances here in our mouth and nose. So if we are laughing or talking and the droplets are coming out, they're going to have antibodies and other things on them. But these are not very protective. These are not very useful. Neither are these very hurtful. They're not harmful. They're just too small a quantity.
I haven't heard anyone working on long COVID, major government effort similar to the vaccine. Long COVID is a much more difficult problem than developing a vaccine. The guys that did the vaccine maybe were lying, but they said it took them a week to develop the vaccine, and then it was all testing. So I don't know of any India-specific data on the BA 4.6. But I have not heard anyone say that they had data or results from people treating that said that it was higher.
M. Gregory, skin doesn't have antibodies. The skin has dead tissue. So if I spit on my skin, then it would have antibodies on it. But generally, the skin's outer layers do not have antibodies on them. Of course, internal layers are all filled with various immune systems and antibodies. Mucous membranes have antibodies, and not all antibodies, IgA. So it seems like this is it. Thank you very much, everyone. And Paul, thank you very much for being here and presenting. And Cool Beans, thank you very much. Tell me this, I'm going to continue this thread for the talk for a few seconds. I am working on a lecture for FLCCC. Would you like to do a chat while I continue to work and you are chatting, or should we meet tomorrow? And also, tomorrow we'll have Dr. Paul Merrick with us at 10 a.m. Pacific time. His topic is how not to let food kill you. And that is a very interesting discussion that he has. So please make sure that you're aware, 10 a.m. Pacific time tomorrow, Dr. Paul Merrick. And if you would like to do the chit chat, I'm actually behind. I had to do that lecture today. So I'm still working on it. So I would continue to work on it. If you want me to turn on the chit chat, I can. Thank you very much. And I'm going to look at the chat after this. And please like, subscribe, and share. And there are links in the description if you would like to support this work.